everyone to Uncommon Knowledge. I'm Dr. Taiwo Jerwade. Today, I have with me a very special someone. She's very special to me. Her name is Dr. Oluchi Oke. Dr. Oluchi and I met in medical school. And I got to know Dr. Oluchi when we did an internship together in New York. I got to know her really well. And I thought I was a kind and generous person until I met Dr. Oluchi. And I realized that there are levels to this kindness and generosity. So she's very special to me, and I'm really, really happy and grateful that she decided to give me a little bit of her time today on Uncommon Knowledge. Dr. Oluchi is the assistant professor, I want to say this correctly, assistant professor of breast medical oncology and a high-risk critical cancer genetics specialist at MD Anderson in Texas. Now, if you know anything about, cancer treatment, MD Anderson is one of the biggest institutions in the United States. So Dr. Oluchi is Ivy League status. She's smart. She knows what she's talking about. So we're very excited to have her on Uncommon Knowledge today. Hi, Dr. Oluchi. How you doing?
Hi, Taiwo. Thank you for having me.
Absolutely. I want you to speak a little bit louder so that we can hear you, okay?
Okay, I'll try. Yes, I will.
All right. So tell us a little bit about yourself. What do you do? I did a little bit of technical introduction, so break it down for us. What do you do on a day-to-day?
So I'm an oncologist, medical oncologist. So I'm the one who prescribes, the chemo or the pills or whatnot, and monitors patients that have cancer. I specialize in breast cancer, so I pretty much only see breast cancer now. And so that's what I do. I'm mainly a clinician, but I also have some appointment in doing some research as well. So I'm starting to open clinical trials. And then I also have an interest, my main research interests are pregnancy and breast cancer. And I have done things in male breast cancer as well. Okay. And then I'm shifting a little to doing a little bit of, focusing on kind of de-escalating some therapies for cancer. Because sometimes there are some people who are, exceptional responders to some of our treatment and do quite well. I may not need all the treatment. And so I am opening a couple clinical trials. One I have recently, a couple months ago, trying in triple negative breast cancer, trying to see if people show that they have an exceptional response, can they stop chemo early? And so that's what I've kind of shifted to doing. So
that's fascinating. So a couple of things you said that I want to touch on. You said breast cancer and pregnancy. I'm an OBGYN, and so I know that this is going to be something of interest for me. Also, the second one, when you said de-escalating, meaning giving people less treatment for the cancer that they have and see if their survival is still good.
Yes, exactly.
Okay, wonderful. Are you able to share anything from what you found, or is it still confidential?
Well, the one with the pregnancy and the breast cancer, we've actually already published, and then so with MD Anderson, we have a couple of pioneers who actually created a regimen since actually the 80s, where they were able to administer chemotherapy to pregnant women.
Wow.
And so we did an analysis that actually presented at the San Antonio Breast Conference a couple of years ago, where we took a cohort of the pregnant patients who we've been treating since the 80s and compared them to non-pregnant patients at the comparable age, stage, and race. So we tried to make the even comparison in that standpoint. And we found that, if you follow them long term, that they don't do any different. So the average timing that you see that people's cancer come back or not come back, because some of them, their cancer has never come back, and then, we consider them cured. It's about the same, the percentage is the same on each group. And I think that's because, now we found that one of the main drugs that we give during breast cancer is a drug called adriamycin. It's an anthracycline. We
Right.
found that we can safely actually give it to pregnant women. And so
Wow, 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 wow.
as long as you give it to them starting in the second trimester, then we haven't seen a difference in overall survival or outcomes. And so
That's remarkable.
that's what we found, at least for that. The de-escalation trial just started 2 months
Just
ago.
started, okay.
We don't have that data yet.
But that's remarkable. So adriamycin is the medicine you give to pregnant women who have breast cancer.
Yeah,
And there's a second one you said.
so you can give adriamycin and cyclophosphamide. The other name for that is Cytoxan. And
Okay.
you actually can give 5-fluorouracil as well. Okay.
And all those are safe for the baby
Yes, all those are safe for the baby and the mom. And
and
then
the mom.
also we have some data to suggest that taxanes or Taxol could be safe as well. And we
Oh,
have given
wow.
pregnant patients Taxol, and we're actually collaborating with a group in Mexico, putting together all the people we've given Taxol to, and trying to figure out, what their outcomes are, because that is still a little bit questionable.
Okay.
We don't have as concrete a data as we have with the adriamycin and the Cytoxan.
And the Cytoxan.
Yeah, but we now more and more people are giving the Taxol during pregnancy, so we're now trying to get that data.
Wow. So adriamycin and Cytoxan, safe for the mom, safe for the baby, can be given in pregnancy. Survival rate, like they do as well as those who are not pregnant, who that's their routine treatment too.
Exactly.
Okay, that's amazing. That's amazing work. I look forward to hearing about the de-escalation therapy as well, because a lot of people worry about the toxicity of chemo.
Exactly, like the long-term toxicities, the some of them don't show up for 6-7 years. You can, meaning like the adriamycin can cause heart failure, but doesn't happen for some years. It's like,
Okay.
and the adriamycin can, and very rarely can cause leukemia, but that doesn't happen for years.
Okay.
And so it's one of those things, if we can spare some people from getting these.
From getting those, reduce the amount they're getting, reduce the chances of leukemia and heart failure later.
Exactly.
Wow.
That would
That's
be
some amazing work you're doing.
yeah.
I'm super excited to be associated with you.
Yeah.
Um, one thing I wanted to ask you is, what I know your job is, you're seeing people when they're most vulnerable, when they're in a very difficult situation. But what would you say is the best part of your job?
I think the best part of my job is also is just being able to go through the journey in general with them. Okay. So when you get diagnosed with cancer, it truly is a journey. Life does not stop for cancer, but you still have to, continue to, battle cancer despite everything going on in your life. And then so what I do enjoy is being able to not only to give them the wins sometimes that they get during this journey, whether the win is making it so that we adjust the schedule or the treatment to the point where they can still pick their kids up from school, still do what they need to do at home because to make their life a little bit easier, right? Or to the actual wins where I clap for them at 5 years because the cancer hasn't come back and graduate.
Cancer free.
So it is nice to be able to do that with some of your patients in general. Sometimes they're little wins, right? Like meaning that they still get to have a good, decent quality of life because of how you adjusted or prescribed their medicine. Others, it's kind of big wins where they've been cancer free for how many years. That's what I like to enjoy is the going through the emotions and doing the journey, with these little to big wins that the patients get.
Well, that's amazing. That's amazing. And I bet you're able to make deep connections with those people throughout that journey.
Yeah, very much.
That's
so.
Amazing. So why do you notice a difference in how people handle cancer depending on the generation they're in? Younger generation versus older generation, emotionally, I would say, and survival rates, I would say.
Yeah. It is different, you know. I do think that older generation, a lot of them, you know, sometimes when you're older, you have a perspective that you've lived a life, you know, and some of them, you know, they do want to be aggressive with their treatment, but not as much as the younger people, right? The younger people,
Wow.
you know, a lot of them are at the stage where they have young kids, right? Or they haven't had a chance to have kids, you know.
Mm,
And then so they are the ones who are, you know, wanting to be aggressive. And most of them, not all of them, but most of them are, you know, like hit me with what you got. They just
mm.
want to do what they can to be able to,
Live a
be
longer
here,
life,
is
right?
live a longer life, you know, and then, but then also at the same time, you know, preserve their fertility and things like that.
Right, right.
So I think what it is more so with older people, because they have maybe more comorbidities, they're kind of like, let's do the treatment to the point where, you know, hopefully I can have a longer life, but at the same time, please don't affect my diabetes control, my this, you know, start to
Mm,
control or make, you know, my heart already has issues. I've already had a stent, we don't want to
mm,
affect it too much. While younger people who don't have much comorbidities are have other priorities. They're like, you know, treat my cancer, make me live longer if you can, but you know, help me preserve my fertility,
mm.
help me still be able to do the treatment and, you know, be able to have energy to take care of my young kids, you know, things like that. So I think that
Right, right.
the goal is always to live longer and to, you know, try and do what you can to get rid of the cancer. But, you know, how you do and how you approach it may be a little different, you know, based on the age, you know.
Absolutely. Just to kind of summarize what you said about the different age ranges. When they are younger, they want more aggressive treatment because they want to live longer and preserve their fertility. When they're older, they want the treatment, but they don't want what they're currently dealing with to be worse. So diabetes, um, hypertension. If the treatment is going to worsen the other things they've been dealing with, they might be less aggressive in what they are able to do
Yeah.
and what
And
they're
that's
willing to do.
exactly. And that's just a general sense, right? Again, everyone has a different perspective on life. I have had younger people who say, I want more quality than quantity, you know? And I've had older people who are 80 and say, I want you to give me all the chemo you want, you know? It's not
Mm-hmm.
common, but it does happen. So everyone is unique, but at the
Right.
end of the day, in general, that's what you usually see. Yeah.
Okay. Wow. Thank you for sharing that. So let's move to the uncommon knowledge part.
Okay.
What do you think is common knowledge that people need to know, or women in general need to know about breast cancer and about the risk of breast cancer?
I think, you know, one of the things I hear from a lot of patients is, you know, how did I get this, right? You know,
Mm-hmm.
I don't have a family history, right? When realistically, only about 5 to 10% of breast cancers are hereditary, you know. Many of the breast cancers, you know, in general, apart from, you know, like skin cancers, like, you know, squamous cell and basal cell, breast cancer is the most common cancer, right?
Mm-hmm.
So, and if you look at how many people are being diagnosed yearly, you see that it's really not something that is just only genetically driven. So to say that, what I'm trying to say is that yes, if you have a family history, you should be quite vigilant. You should see if there's been genetic testing done, and if not, try and get people to get genetic tested to see if there is a gene that runs through the family. But in general, everyone needs to go get their mammograms, at the appropriate age. Usually the appropriate age for most people who don't have like a potential hereditary link to breast cancer is, 40. Okay, that's usually the
Mm-hmm.
recommendation. And then so that's what I would say is that, despite, you not having a family history of any cancer, it's still important to do the genetics because there are many more than not, most patients who come to me don't have family histories. Okay. Um,
So just to touch on that, you said most people who have breast cancer don't have a family history of breast cancer.
yeah.
And so you said genetics. What would prompt people to go and get genetics?
I would prompt you to go get genetics if you find that you have at least two people or more,
Mm,
breast cancer or anyone with ovarian or pancreatic cancer as well. Okay, those are the ones that I would check to see if if the person is still alive, usually if you have pancreatic cancer or ovarian cancer, they automatically test you for a genetic link, right?
Okay.
And so I would ask that person if they're still alive, was that done? And then if,
Okay.
at least two members of in your family that have breast cancer, or if anyone had what we call triple negative breast cancer, but if it's just one member, you should ask them to see if they've had genetic testing as well. Those would be the people who you would want to know. And not all of them have a genetic mutation that's positive, just because they have those cancers. I will have a family. I'll have a patient who has like 5 members of their family with breast cancer, and not a genetic link. And
Oh,
it's not
wow.
clearly there is a genetic
Right.
component to it with 5 members. It's just a gene that we haven't discovered yet, right? Up
Okay.
until 2015, really the only genes we were testing for was BRCA1 and 2. But since then, more genes have come out. So it's just a matter, as the field of genetics evolves, we may be able to find whatever that gene was that linked that family, right? Now we don't know all genes, but there are some genes we know about and recommendations we can make if you have these mutations. Okay.
So if someone has more than one family member with breast cancer, they should get genetic testing done to look for a genetic.
They should, the person who
identifier.
had, the person who has the cancer should be the one to get the genetic
The
test.
person who has the cancer should be
Yeah.
tested for a gene,
Mhm.
or hereditary gene.
Yeah, exactly. Yeah, because
If-
if the person doesn't really have the gene, then it wouldn't really pass down to you, or the gene that we know of wouldn't really pass down to you. Like if they don't have a gene that we've discovered yet, then they wouldn't have passed it down to their children or whatever. And then then if the child gets tested, then it would still be negative. So that's why you always start with testing the person who actually had the cancer.
Okay. So if someone in the family has breast cancer, that person should, if that person is still living, it would be beneficial for that person to get tested to find out if there's a hereditary gene that can be passed on to other family members.
Yes.
The limitation is that we've not discovered all the genes possible. So it's possible that it comes back negative.
There's a criteria you have to meet to get genetic testing. And so it's the person who actually has the breast cancer. And then if that person also has 2 or more family members, right? Or if that person is a certain age, anyone diagnosed with breast cancer under the age of 45, we test because it is young to have it, right?
Okay, right.
But the key thing is it all starts at the person who has the actual breast cancer.
Okay.
So any patient who has triple negative breast cancer, any patient who has 2 or more any breast cancer patient themselves that's 2 or more family members with breast cancer, any breast cancer patient themselves that's younger than 45. They will be the ones that get tested. And you start with the person with the cancer, and then if they have a gene, then they will educate the family members, usually siblings and children, and maybe even parents too, who will need to get tested.
Okay. And then for everybody else who has no family history of breast cancer, they should get their mammograms at age 40.
Yes, you should get your mammograms at age 40. However, the other thing that people come to me and don't realize could be an issue is the breast changes that you sometimes see, and so if you have any of these following breast changes, this is another reason to see your doctor and potentially get a mammogram and ultrasound earlier of your breast, okay? Earlier than 40. So if you start to see any inversion of your nipple, that's not usually.
Like the nipple is going inside?
Yeah, the nipple is going inside, that's not, that could be signs of the breast cancer. If you start to see the skin in general dimpling, that could also be a sign as well.
Skin dimpling, so sort of looking like the skin of an orange?
No, like skinning, like the dimple, like in your cheek, if you have a dimple in your breast, those could be early signs as well.
Okay, wow. Okay.
Sometimes even dryness in the nipple. A lot of people have dry nipple, just to start with that. So, but this is a dry nipple that, with moisturizing it really does not improve, and it also starts to evolve and get more dry and form more thickness. Sometimes that could be a rare type of breast cancer called Paget's disease as well. And then
Wow, so dry nipple that does not improve with moisturizing
and then
and even starts to get drier and thicker.
yeah,
That could be Paget's disease, which is a rare form of breast cancer.
Exactly. So those are some of the things that people will say, well, about 6 months ago, or a year ago, I did notice that my nipples started to look like this, but I wasn't, I just thought it was normal breast changes,
Right, right.
Especially, with me dealing with a lot of, pregnant patients, there's so many breast changes
Right,
pregnant and even after, right, because of the milk.
right.
And then so it's, if you have an inkling that, sometimes it can be a plug duct, but plug ducts, a lot of times we can relieve, with warm compress, with massaging and things like that. If it continues to progress and get bigger and does not get relieved, that could be something concerning, and you should see your gynecologist about that to get that evaluated. Sometimes it ends up being nothing for some people, it does. But we want to know that, and so that in the future we can know that it's a cyst or fibrocystic breast, and we won't want to have to miss the breast cancer. Okay. Or it could even be a precancer lesion, right? Like a high risk lesion that's not actually cancer yet, but then luckily we would have caught it at an early time.
Wow.
And so that's why
some of those signs can help you get the breast cancer, catch the breast cancer
earlier. Exactly. So that's why it's important to be doing your breast exams, but part of your breast exam is just not being in the shower doing this, it's looking at your breast.
Looking at the breast.
Yeah,
okay. Part of your breast exam is looking at your breast.
Yeah, so
not
that's
just
very,
feeling
very
the
important.
breast.
Exactly. That's one of the things. The other thing, I was asked, what could I have done from a lifestyle point of view, right? Reduce my risk of, breast cancer. Just like many cancers, we are seeing a correlation with, obesity and cancers, including breast cancer. Not only can estrogen be made in ovaries for, premenopausal women, but it's also made in our fat cells as well, And then so we are seeing a correlation with obesity and increased risk of breast cancer. We're also seeing there's also a correlation with increased alcohol use and breast cancer as well. We've learned that if you drink up to 2 drinks a day or more, you can double your risk of breast cancer.
Wow.
And then
so the first thing you mentioned, more fat in our bodies, more estrogen. That more estrogen can increase the risk of breast cancer.
So physiologically, in general, we don't necessarily say it's the case, but because we don't know that as an actual
cause.
Yes. Okay. But then we have seen with increased obesity, right, that we see increased risk of breast cancer. And then so we're thinking, is that related to that? Because you have more, unopposed estrogen, right? Because you're making more. So is that the case or not? That's, a consideration. So it's not like we know that is the exact cause. It's just more so it's one of those things that rather than a causation, it's more of a correlation that
Okay. And then you said if you drink 2 or more glasses of alcohol a day?
Alcoholic beverages a day. Yes.
Alcoholic beverages. Yeah. 2 or more a day can double your risk of breast cancer. Okay. Yeah. That's good to know.
Yeah.
I don't know that a lot of people know that.
Yeah, I don't think a lot of people do know that. And I think in general, everyone always talks about, a glass of wine, it's good for your health, all these things and everything like that. But, at the end of the day, this is another correlation that we've seen quite significantly, actually. And
significant correlation, you would say, with alcohol.
And so it is something that we recommend that people reduce, significantly. When I counsel my patients, so they're not tempted, I say, 4 or less drinks a week. That's how I counsel my patients. That's what a lot of our nutritionists will say as well, to try and reduce the risk,
Okay. So what people can do to reduce the risk of breast cancer is less than 1 glass of alcohol a day.
Yes, and then also, I would think it also, exercise
weight management
and weight management with especially low carb diet.
Low carb diet. Okay.
Right?
Okay.
Because, and then if there's been genetic testing and it's been negative for any gene we've actually discovered, right? Then it's one of those things where if there's at least two members or more with breast cancer, I would recommend, getting your mammogram at 35 instead of 40.
At 35 instead of 40. Okay.
Yeah, and then
Wow, that's remarkable.
those who have genes in the family, their recommendations for when to get mammograms and even breast MRIs are different, which it would be quite complicated to go into now.
Right. That would be on a case-by-case basis.
Yeah, but
Right.
everyone would you would of course meet with a genetic counselor and someone like me, like a high risk, consultant, and we would explain that more when we recommend that.
Okay. So those who actually have hereditary genes will meet with a genetic counselor, will meet with a geneticist like you, geneticist consultant, and they can come up with a plan of monitoring for them so that they don't get the breast cancer.
Exactly, or discuss with them if the risk is high enough, at what age we would recommend prophylactically doing mastectomies. Some genes are associated with ovarian cancer. There's some ages that we recommend prophylactically removing the ovary and the fallopian tube. So it just depends, but that's if they have
a positive gene.
Yeah, and those are the biggest genes that are known for that to have a strong recommendation to do those things is the BRCA1 and 2 genes.
The BRCA1 and 2. Okay. Wow, lots of information. This definitely helped me as a gynecologist, so I can tell my patients these things when they come into the office. And definitely information that I think should be out there for people to know, so they can be on top of things. They can advocate for themselves when they go to their doctors and say, hey, I have this information, what should I be doing?
Yeah.
So I really appreciate you sharing that with us.
Thanks. Early detection really, I know this is like the cheesy saying, early detection saves lives, but it's so true.
Okay.
Those are the ones with
early
the good
detection
prognosis.
saves lives.
Those are the ones who are 30 years, and saying I have not seen my cancer for 30 years, Those are the ones, those early stages. And so early detection really does save lives,
Wonderful. Thank you so much for your time. I really appreciate it.
No problem. For you.
We hope to have you back when we have more questions on this topic. So
okay, yes,
be
definitely
prepared.
I will definitely be ready. Okay.
Thank you, Dr. Luch.
Thank you, Dr. Taiwo.